Another thing is the functional. When the control of the plaque bacterial and maintenance, it's very easy when we have a good quantity of a gingiva instead the absence of gingiva. And maintain health by preventing mucositis, lessen the risk of a peri-implant implantitis. This is, we have case like this case, it's 23 years following up, and it's very stable and very good result on the time. This is another case, 25 years. And look how it's stable, the bone and the gingiva and everything. So the implant, if we place it very well in 3D and we maintain very good hygiene thanks to a good presence of quantity, quality of gingiva, really they have very good follow-up in the time. In this in this study, you listen me?
Yes, yes.
Okay, because okay. In this study of the school of Linkevicius and Earl, they demonstrate that when we have a thickness tissue around the implant, 2 millimeter or less, crystal bone loss up 145 millimeter despite a supercritical position of the implant abutment interface. So you can think about how it is important the quantity, the thickness and the height of the mucosal thickness around the implant. I will show you now how we increase the soft tissue. If you observe this photo, we have a good osseointegration of the implant, good aesthetic of the crown, but bad aesthetic of the gingiva, and we have a big defect in this area, so the patient can't absolutely clean and maintain the hygiene in this case. So with a graft of gingiva, we obtain this result, who is very nice, and it's too simple to maintain cleaning, and aesthetically is more best than the first photo. So increasing the soft tissue, we obtain better control of the plaque, aesthetic, and the stability of the margin bone. How we guarantee the stability of the tissue around the implant? We have many risk factors to avoid. The lack of keratinized mucosa, it's very important to observe if we have a good mucosa or no. If we have a thin phenotype or if we have deficiency of the volume of the bone, and especially when we work in the upper jaw in the frontal side, we should remember that the bone is very thin, and after extraction we lose the vestibulary bone, because it's the bundle bone, is the periodontal bone. So we should be very careful to analyze the situation, the side of the implant, and to avoid to have this disaster like you see in this photo. It's very important, like I said before, the 3D position of the implant and how to make the structure over the implant and how to guarantee the access to the maintenance of the periodontal case. So, a width of keratinized mucosa of 2 millimeters and the thickness of connective tissue seems to be the dimension directly related to the choice of the surgical procedure for tissue reconstruction. So when we have a tissue less than 2 millimeter, it's absolutely recommended to increase the width and the height of the gingiva. So it's recommended to do something to increase this tissue. And how we can increase this? We have several techniques to increase the gingiva around the implant or around the natural tooth. It's the same. We have the free gingival graft, apically positioned flap or vestibuloplasty, the xenogenic graft, full thickness flap, and a subepithelial conductive tissue graft, and the xenogenic graft. The connective graft that I use, and I suggest you to use it because it's stable in the time and aesthetically is really, he mimics very well with the other tissue. You can harvest it from the palate, and it's a symbol of connective tissue, therefore deprived of its epithelial lining, which is completely detached from its original site without any basis for its nutrition, and applied to another side. So we harvest this graft from the palate, and we place it in another place, in another side of the mouth. And how to do it, and what is the important from a point of view of the anatomy to make some evaluation before the harvesting of the tissue. We remember that we have here, sorry, the greater palatine artery. The palatal tissue thickness, it's very important to to know how it is before makes the harvesting, and we make in the side where we will do the harvesting, the probing to know if we have some pocket or no. And it's important to do also intraoral X-ray. Some numbers is very important to remember. The distance between the CAJ of the upper second molar and the emergence of the neurovascular bundle, it's around 17 millimeter in the high palate, and it's around 12 millimeter in the mid palate, and it's 7 millimeter in the low palate. This is important to avoid to cut the artery in this emergence. How to do this? With our scalpel, we make a horizontal incision toward to the bone crest, flap dissection with a parallel incision, graft release using the periostal elevator to the underlying bone, and after lateral and apical incisions, and after we remove our graft and we give the a cross loop suture. It's very important to make several cases like this to have after the maestry to do it. Which characteristics the graft should have? It's depend about the thickness. If I want to cover a root, I need 0.8, 1 millimeter for this coverage. But if I need to cover metal edge and implant, I need absolutely around 2 millimeter thickness for my graft. So we know in the natural tooth, the width of the graft is very important because must reach at least the center of the papilla of the adjacent teeth, and the land is defined based on the distance between the CAJ and the buccal alveolar bone crest. If in my assessment before, I find a fibromucosa thickness 2.5 millimeter, so when I do my harvesting, I can have only 1 millimeter of thickness for the graft, because the epithelial layer, I should leave a minimum 0.5 millimeter to support the epithelial layer. If no, it's go in necrosis. And I need also 0.5 millimeter to protect the bones, a palatal bone. So if I have 2.5 millimeter, I can have only 1 millimeter thickness for my graft. So I can coverage also natural root. A fibromucosa thickness 3.5 millimeter, leaving 0.5 millimeter to support the epithelial layer and 0.5 millimeter to protect the bone, I can have 2 millimeter to cover the implant or metal, other metal crown and all.